Assalamualaikum warahmatullahi wabarakatuh. Welcome to my channel of Easy Medical Notes. Myself, Dr. Rais Khan. Previously, we have discussed about the definition, causes, and clinical features of cough. Let me summarize the previous class briefly. So first, we had classified the cough into respiratory system, respiratory cause, cardiovascular cause, GI cause, neuromuscular cause, or drug-induced cause. Then second, based upon duration, acute, less than 3 weeks, or subacute, or it can be chronic. In acute and subacute, always we should rule out aspiration before telling that it is a viral URTI. We should consider this in mind. We should rule out these causes, concerning causes: aspiration and pneumonia, and next is pulmonary pulmonary edema, and pulmonary embolism. We should rule out these causes. And if these are not there, if the clinical features and examination does not suggest these things, then most likely it is due to a viral infection of the respiratory tract, upper or lower. In chronic, most common causes in India like tuberculosis, lung carcinoma, interstitial lung disease, and bronchiectasis. Now, we will take history and do examination and perform investigation based upon the history and examination. If you don't find any pathology, then most likely the cause can be due to cough variant asthma. Second, COPD. Number third, post-nasal drip due to chronic rhinosinusitis or sinusitis. Number four, drug-induced cough due to SC inhibitors. Drug-induced. Okay, these will be the four common causes which will be contributing the cough if we have ruled out these causes after investigations. Now, this was the second type of classification. Third one is characteristic of cough. Whether it is purulent, whether it is non-purulent, whether it is bloody, whether it is bloody, whether it has food particles in it, and whether it is having some aggregates, thin aggregates, fungal aggregates. Okay. In purulent, whether it is copious or not. If copious, then bronchiectasis is the cause mostly, or a lung abscess rupturing into the bronchus. Whether it is foul smelling, if it is foul smelling, then anaerobic bacterial infection or aspiration. This we have discussed. If non-purulent, mucoid sputum. If it is sputum is mucoid, then the cause can be COPD, asthma, pneumonia. Okay, or clear viscous sputum, asthma is the cause. If it is bloody, meaning hemoptysis, then tuberculosis, carcinoma, bronchiectasis, pulmonary edema, acute left ventricular failure. Okay, then pulmonary embolism, massive pulmonary embolism, mitral stenosis, all these cause bloody hemoptysis. Food, whether food is present, then there can be tracheoesophageal fistula. This you should have, you have to differentiate this with hematemesis, where blood is vomited from stomach. There also you find food particles. Again, here also if you find food particles, then you have to differentiate between these two. And if it has blackish aggregates or some different features, here it is there no aggregates and plaques, if you find, then it is mostly some fungal ball in the lung parenchyma, like allergic bronchopulmonary aspergillosis, which is mainly found in asthmatic patients. So these are the causes. This we have discussed before. Okay, now now we will move further in investigation. First you will take history and examination. How you will take history and examination? You will take history and examination focusing on those majorly three systems. Four systems are there, but in that four system, three systems are important: RS, CVS, and GI. Okay, focusing on these three, and in these three also this one, you take the history and perform the examination, physical examination. You press the frontal sinus, maxillary sinus, you examine the pharynx, examine the throat of the patient, examine the larynx of the patient, examine the chest, hear the sounds, and percuss the stomach, palpate the stomach, or palpate the stomach. All these things you do in physical examination, focusing on these systems. Next, what you will do? To evaluate for a cough, you should differentiate the cough into acute, subacute one side, and chronic on another side. In acute, subacute, if acute, subacute cause is mainly if not here it is there, if not accompanied by symptoms causing concern, like if the cough is not associated with dyspnea or hemoptysis or weight loss or fever or night sweat or loss of consciousness or chest pain, then it is usually caused by viral lower respiratory tract infection or post-nasal drip resulting from rhinitis or sinusitis or aspiration of a foreign body or laryngitis or pharyngitis, meaning the cough is mainly caused by the respiratory tract infection. Okay, and if this is if the cough is associated with these things, with breathlessness, with hemoptysis, with weight loss, fever, night sweats, all these things, then you have to evaluate the patient further. Okay, gives this history and you will examine the patient, and in examination you find something, you have to evaluate the patient further. In examination, basically what all tests we do chest x-ray and pulse oximetry, ECG and 2D echo, high resolution CT scan, bronchoscopy and pulmonary function test, sputum microbiology. But usually first what we will perform is chest x-ray, and if it is productive, sputum microbiology. These two will perform. And if we are not getting anything in this, we will go to CT scan, HRCT thorax. These things a general physician will do. And if he is suspecting some cardiovascular cause, he can do ECG. Above this, still something, you are not finding something, not finding even after doing all these things, then you should refer the patient to a pulmonologist for bronchoscopy and pulmonary function test, or cardiologist for 2D echo. Okay, in case of acute and subacute cough, remember to rule out those four things before saying it is due to upper respiratory tract infection, and before ruling out these concerning causes. The next is chronic cough. In chronic cough, again same investigations are there, but only two are added in this. One is ENT evaluation, and the next one is GI endoscopy and esophageal pH manometry, meaning some electrode is kept in the lower part of the esophagus where you monitor for pH, and you will diagnose whether there is GERD, whether there is reflex is there or not. Okay, that is pH manometry. You will measure the pressure of the lower esophageal sphincter also. So these two are additional in chronic cough. Again, you will evaluate same for the chronic in the same same way as in acute and subacute cough. You will do chest X-ray and if there is sputum examination, and if you are not still concerning, then you will go to HRCT thorax. Above that, you will refer to some pulmonologist or cardiologist if you are suspecting cardiac cause. And if you are suspecting some ENT cause, you will refer the patient to ENT evaluation. And if you are suspecting some GI cause, you will perform GI endoscopy, refer the patient to a gastroenterologist. So basic test which a GP perform is, final takeoff from this is, one is chest X-ray, second is sputum analysis, third is HRCT, fourth is ECG. Above this, you have to refer the patient to the concerned doctor. Remember this in this order. Okay. Let us move forwards. Sorry. This is a box showing how to evaluate a cough. What you will do, you will take cough history. You will ask in cough history, what you will ask? I said no. You remember the four examinations and duration and production. These things you will ask, and you will assess on examination cardiac, respiratory, GI, and ENT evaluation. These four things you will do on examination, and whether there is any drug is inhibitor use, and you will ask whether the patient smokes or not. Then you will do some basic tests. You will do spirometry. This will tell you about asthma and COPD. You will do chest X-ray. You will do a simple CBC. If these are there, you should refer the patient. Hemoptysis, weight loss, fever, abnormal chest X-ray. Now, if these are not there, then you can manage the patient in your OPD. If asthma is the cause, you give inhalation corticosteroids or long-acting beta 2 agonist or leukotriene receptor antagonist for 6 to 8 weeks. In case of COPD, you give LAMA, long-acting muscarinic antagonist for 6 to 8 weeks. If there is drug used by patient, AC inhibitor, then there is no other cause like cardiac, respiratory, GI, or upper respiratory cause, then you should suspect AC inhibitor. Then you replace that AC inhibitor with some other drug like ARV. And if there is post-nasal drip, meaning chronic rhinosinusitis, then the drug of choice is intranasal corticosteroids. If there is allergic history also, you can give antihistamines and decongestants for 6 to 8 weeks. And if there is GERD history, you give PPI inhibitor and pro-motility agents for 8 to 6 weeks. So just brief treatment of this common condition. For asthma, you will give inhalers are available in 3 forms. Number 1 is rotahaler for deep explanation of to know more about this, you go and search on the Google. You will find what is rotahaler and how it works. Second is multi-dose inhaler. Third is syncobreath. So these three you will use in case of asthma to deliver the inhalational corticosteroid. Most common rotahalar or multi-dose inhaler which is used is formoterol plus budesonide combination available as Foracort in the market. This is the trade name, Foracort 200 or 400 based upon the dose, MDI. So what you will do, you will say the patient to take this. If again if the asthma is mild, moderate, it is divided to controlled or uncontrolled, and also whether it is mild, moderate or severe. If it is episodic and patient doesn't have symptoms, a patient has symptoms less than 2 episodes in a week in daytime, or 2 episodes during night time, or patient has exacerbation less than 1 per month, then it is considered as episodic asthma, and you can prescribe Foracort 200 multidose inhaler as SOS basis. Means when the patient develops symptoms, just tell the patient to take the inhaler at that time. And if it is moderate or severe, then at that time you say the patient to take it twice daily, morning and evening, for 3 months. Then after 3 months you will assess the response. If there is adequate response, then you reduce the dose of inhaler from twice daily to once daily. And again, and if there is response is there but it is not that adequate, then you increase the puff from 1 puff to 2 puffs morning, and 1 puff in evening to 2 puff in the evening, like that. If you double the puff dose, this will become 400. If you take 3 puffs, this will become 600. Same inhaler. Okay, so you will increase the dose if there is no adequate response. You will decrease the dose if there is response after 3 months. And if again after 3 months, if the patient is doing good, then you will say the patient that take this inhaler whenever whenever you experience the episode of asthma, like that you will manage. Okay, then the most common drug for COPD which is used is tiotropium anticholinergic, long acting muscarinic antagonist, tropium. One more is also there, that is glycopyrrolate, but not used. I have not used this one. Some physicians use this, but mostly used is tiotropium, which is long acting. This is available as, brand name is Tiowa inhaler. Say the patient to take it in the morning once daily, and assess the response after 3 months. And here you don't decrease the dose. Say the because it is a COPD is a progressive disease, that's why you say the patient to take it continuously. And the main thing of COPD is tell the patient to stop smoking. If he doesn't stop smoking, then the dose will also increase, and along with Tiowa, you need to give later after some time Foracort also to this patient. Okay, after that you have to give this one, what do you call, Asbroflin, theophylline you have to give. After that there is no roflumilast is there, one option, roflumilast. Okay, like this is the cycle how you prescribe a COPD patient. With the last step will be oxygen therapy to the COPD patient. Okay, if there is no cause, then say the patient to remove the ACE inhibitor. In chronic rhinosinusitis, drug of first choice is intranasal corticosteroid. Most commonly used is fluticasone furoate. Available as brand name in the name of flow mist nasal spray. Flow mist. This I am discussing in some detail because these are very common conditions. Flow mist nasal spray. Tell the patient to take it twice daily. Morning 1 puff, night 1 puff in both nostrils, and come after 3 months. If he has response, decrease the dose. Similar to asthma. If has no response, increase the dose from 1 puff to 2 puff, like that. Okay. And alternative to this is your what do you call, leukotriene receptor antagonist for chronic sinusitis, like montelukast. One more is zephyrleucast, but that is not used routinely. Montelukast 10 mg OD, along with some antihistaminic, may it be levocetirizine or fexofenadine or bilastine or loratadine or desloratadine. But remember, fexofenadine should not be given in pregnant ladies. Safe drugs are levocetirizine and loratadine in pregnant ladies. And in pregnant ladies, steroids are also safe. Inhalatory steroids we can give to those asthmatic ladies who are pregnant. So in pregnant ladies, inhalatory corticosteroids are safe. Okay, LABA is also safe, but SABA is not safe. What is SABA? SABA is short acting beta agonist, that is salbutamol or levosalbutamol inhaler. This is contraindicated in pregnancy by inhalation also. So LABA plus steroid is the preferred inhaler in pregnancy. Okay. So this LTR, montelukast with some antihistaminic, is the second alternative drug of choice for chronic rhinosinusitis, and you can combine even that nasal spray with this, then you will get a very good response with that. But it can't replace that intranasal steroid spray because it will prevent formation of polyp, and if there is turbinate hypertrophy turbinate, even it will decrease the size of turbinate, that intranasal steroid. And next is GERD, reflux disease. The drug of choice is PPI. Most commonly we use pantoprazole, but it should be used in these patients who have cough due to laryngitis, acid laryngitis, 40 mg BD twice daily. Just having GERD, no respiratory systems, no cough, 40 mg OD is enough according to guidelines. But if there is extra GI symptoms with GERD, then 40 mg BD is the preferred dose. Then you will monitor for 8 to 12 weeks, and then you will try to reduce the dose to 40 mg, and most of the times it will continue for life in patients GERD. Other drugs which you can give after if you don't give pantoprazole, alternative drugs are rabeprazole and pantoprazole, rabeprazole, esomeprazole. Okay, these are the drugs. Now, if the cough is still not resolving with if you are treating these conditions, if it is not resolving, then you should do, this is a chart, step by step approach it is giving. Then you should do, again you should confirm asthma, confirm GERD, confirm esophageal dysmotility, any dysphagia by manometry. Okay, for post-nasal drip you refer for ENT, or you do CT scan of the sinuses, and you suspect non-allergic, non-asthmatic eosinophilic bronchitis. For that, sputum, bronchoscopy, biopsy, bronchiology we do. So first what you will do, if after all these measures the cough is not resolving, you confirm further the diagnosis by further test which evaluate those three systems. Again, if nothing is found and the cough is distressing and it is persistent and interfering with the life of the patient, you grade the severity of the cough according to cough severity, like the visual analog scale from 0 to 10, being 0 for no cough, 10 for very severe cough. Then you will assess, and if the cough is persistent still after re-evaluating also, then you will go to the it is labeled as refractory or unexplained cough, and you will give these drugs pregabalin, gabapentin, amitriptyline, okay, along with speech pathology, speech therapy. This is the approach. Then coming to treatment of cough, main treatment is treatment of the cause. You treat the cause. Along with that, you treat the cough symptomatically. Okay, treat the cause first. If there is no cause, like we have discussed in this chart, if there is no cause, then you will go for central acting. You will label it as refractory cough, and you will give central drugs. For treatment of for productive cough with sputum, our main goal should be to remove the mucus and help the patient to expectorate all those secretions. Okay, and in dry cough, cough has nothing to do with, because there is no secretions, nothing is there, just it is troubling the patient. So for that you will suppress the cough. Here you will suppress the cough, here you will thin the mucus and induce the cough for the removal of secretions easily. Symptomatic treatment of productive cough. Measures that facilitate the evacuation of airway secretions and increase the effectiveness of cough. Respiratory physiotherapy. What will do? Postural drainage, chest percussion with a cup like this. Educate the patient how to cough effectively. Okay, so first respiratory physiotherapy. Next is, this is very important, nebulized hypertonic saline, whether it is 3% or 7% sodium chloride. Before giving the nebulization of this saline, you pre-treat the patient with a bronchodilator. So nebulization with a bronchodilator should be given, or else what you do, you put the bronchodilator respule and 3% does both, uh, mix both and give it simultaneously, both simultaneously. But don't mix this 3% or 7% sodium chloride along with steroid. A practical point from me, because it will become very thick solution, and it will go very slow, very slow it will go. So what you do, if you want to give some inhalatory, if you want to give steroid by nebulization, just you give 3% saline along with beta 2 agonist. After giving that, separately you use steroid. Nebulized hypotonic saline. So this will break the bonds in the mucus, it will thin the mucus, it is bactericidal also, and it will hydrate the patient also, and it will induce the cough also. So it is very good, and it is very evidence-based treatment nowadays for treatment of symptomatic treatment of productive cough. Okay, next is mucolytic agents like acetylcysteine. One more thing I want to say about 3% NS. This is also given in acute bronchiolitis in children's. Acute bronchiolitis. Okay, acute bronchiolitis also it is given, where children's come in winter or summer season from 6 months to 5 years of age, with increased parents bring the children with increased rate of respiration. Abdomen will be there will be abdominal breathing along with intercostal muscles recession. So but there will be no history of fever. Patients will say the child had cold, and now the child has developed this increased rate of respiration. SpO2 will be normal in these patients. In these patients, the best drug according to IAP is 3%. Epinephrine is also not useful, and steroid is also not useful in this way. 3% is the drug of choice by nebulization for children having acute bronchiolitis. It has reduced number of hospitalization very much by using this 3% NS saline. Okay. One more thing, IAP also says that if the child's parent has one or both the parents has a history of allergy, then you can also use beta 2 agonists with this 3% NS. Other agents are mucolytic agents like acetylcysteine, available as Mucinex brand name outside. Mucinex 600 mg once daily effervescent tablet. And this is also used in PCT poisoning, paracetamol poisoning, and also used in alcoholic hepatitis. Remember this additional information. So mucinex is also used. So main thing in productive cough, what you give a patient comes with upper respiratory infection, you will give these two, hypertonic saline along with the bronchodilator and mucolytic agent. These are the drugs which are given. That's all. Acute patients in OPD. Then low dose macrolide antibiotic like azithromycin 250 mg daily or alternate days for 6 to 12 months. This is given in patients with severe COPD or bronchiectasis who have recurrent exacerbations. To prevent the exacerbation, you give this, but you should monitor the side effects, which include it causes QT interval. So you should monitor the cardiac. You should monitor the patient for cardiac arrhythmias. You should monitor the patient for hearing because it has effects on hearing loss, and you should monitor the patient for GI adverse effects like diarrhea. And the most common adverse effect if you give this low dose micro antibiotic is diarrhea. Remember, with this one thing I want to discuss one thing. Any patient of any chronic smoker having COPD coming with recurrent exacerbations, recurrent meaning more than 1 to 2 per year exacerbations are there, then first you should rule out any pathology in the chest, whether there is lung carcinoma or not, by chest x-ray or HRCT, or TB, whether there is TB, you should rule out. Three things you rule out: TB, carcinoma, and bronchiectasis. You rule out these things. So if you don't find TB and carcinoma and you have bronchiectasis, then you should give this drug. If the patient of COPD has recurrent exacerbation, meaning 1 to 2 episodes of lower respiratory tract infection per year, even after giving that Tiova and Tiova therapy, LAMA and LABA. Now this was about that. So mainly in OPD basis we give this box treatments. Remember this. Okay, this is must. Then in palliative care you decrease the secretion because secretions are more. So subcutaneous hyoscine is given or scopolamine is given. And then symptomatic treatment of dry cough. So there are two types of drug which one which acts on the peripheral nerves, one acts on the central cough center. So there till now, first what you do, if treatment of any of the underlying conditions such as asthma, GERD, and post-nasal drip is ineffective even after specific treatments, then management algorithms can consider the following treatment options. What are the following options? Periphery acting cough, you will label it as refractory cough, as discussed here. You will label it as refractory cough. Then you will try these things: peripherally acting cough suppressant. There is only one cough suppressant, peripheral acting, which is licensed in some countries but not in India. That is Gefapixant. One more is there, which we'll discuss in cough in cancer patient. That is levodropiprison. Okay, and this is the drug which acts peripherally, and it is available in cough syrup form also. So peripheral. Then centrally acting. Centrally acting cough suppressants, which is commonly used, is dextromethorphan, but it has little evidence. But still, Indian government uh, 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 suggests to use this dextromethorphan. In children, some countries say to don't use this drug in children, but some in India they say to use this in children, for children's from 6 years to 12 years of age. You can use this for cough, but it is not that efficacious. Then the second drug is, so most commonly used is dextromethorphan along with some antihistaminic. Second one is oral morphine sulfate. This is used in tertiary centers, not given in primary and secondary centers. Now refractory cough is there, it is not resolving. And one more thing in central thing, one more thing is there, one more drug which is not there here, that is levocloparastin. Levocloparastin, I have used this many times. This is a central antitussive available outside as brand name Lupitus 5 ml tristeric. If the cough is not resolving with dextromethorphan, you can try this. This will act as a magic. I have used this drug for dry cough. It is not recommended in children's. Again, if the cough is refractory, then you can try gabapentin and amitriptyline for 8 to 12 weeks. And one more thing about amitriptyline is, in chronic cough presumed to be related to a previous viral infection superior to codeine plus guaifenesin in an open, it is presumed to be related to, means it is used in that chronic cough which is presumed to be related to a previous viral infection, and it is superior to codeine plus guaifenesin combination in a study. Okay, so first in dry cough, what in productive cough, what will you do? Productive cough, symptomatic treatment, 3% or 7% NS you will use along with bronchodilator. Pre-treatment, पहले bronchodilator, first bronchodilator should give, then this one. This is the first drug of choice. Second is you give mucolytics like N-acetylcysteine, okay, N-acetylcysteine and other things. And some patients, specific patients like severe COPD patient with recurrent exacerbations, you will give low dose azithromycin for 6 to 12 months, monitoring the side effects. Okay, this is about productive cough. In palliative care, you will give hyoscine to decrease the secretion in palliative cases. In dry cough, symptomatic treatment, even after treatment of the cause of, even after treatment of the causes of dry cough, if the cough is not subsiding, then you can consider central or peripheral cough suppressants. In peripheral cough suppressant, there is only one FDA approved drug, that is gefapixant, and it is not available in India, it is available outside. In India, you can have this one, what I was talking about is this one, levodropropizin. This drug, this also acts on peripheral nerves. This is available in Indian market as syrups, but this also I have used. This is not much useful for dry cough. So you will give dextromethorphan, still not, cough is not responding. In tertiary care centers, you will give that morphine. Okay, now if the dry cough is not responding to this, then you give, what you will give, you give levocloparastin. This is centrally acting cloparastin, levocloparastin, available as Lupitus brand name syrup. Even after this, if the cough is not responding, you can consider gabapentin and amitriptyline. Okay, other things, speech and antacid. If the cough is due to GERD, give PPIs. Okay. If it is due to cough hypersensitivity syndrome, then speech and language therapy should be given. Cough specific therapy aimed towards education, reduction of laryngeal irritation, cough control techniques, and psychoeducational counseling. This is combined with this. Okay, this is combined with this. Local anesthetics are also used, but like lidocaine as nebulization or by spray in spray type. But they act for very short time. They are not suitable for chronic cough. They are used before bronchoscopy and before air suctioning. You can also try this one if the cough is very disturbing for some patient. What you do, you 1 ml or 2 ml of lignocaine you put in the nebulization machine, and you just inhale the patient for short-term immediate relief of cough. You can try this after dextromethorphan and levocloperazine, everything. Means after for refractory cough, you can, for short-term relief, you can also try this one. For cancer-related cough, the cough is mainly caused by airway edema, compression by tumors, or by pneumonitis followed by radiotherapy or chemotherapy. Then in that cases, you use glucocorticoids. In that, dexamethasone 4 mg twice daily. In other scenarios, you use levodopa-propizine for 6 mg TID, aprepitant 125 mg 1 hour before chemotherapy. One note here, use centrally acting cough suppressants only if treatment with glucocorticoids is inappropriate or ineffective. Centrally acting cough suppressants, use centrally acting cough suppressants only if treatment with glucocorticoids is inappropriate or ineffective. Okay, so this concludes our topic of cough. Next we will discuss about the topic of breathlessness. The slides are already ready. So the time is over, 40 minutes. Sorry for the time. I am trying to reduce the size of the video, but if I need to reduce less than 30 minutes, I need to alter the quality of the video, or I need to go very fast just reading the things. I can't explain the concepts, so I will try furthermore to reduce the size of the video. तो आपके लिए इंशाल्लाह इतना काफ़ी है. इजाज़त चाहता हूँ, और आपसे एक दरख्वास्त है कि आप वीडियो को सीखने और सिखाने की नीयत से इसको शेयर कीजिए, ताकि लोगों में जो है प्रैक्टिकल लोग इसके नोट्स भी बना सकते हैं. स्टूडेंट्स को भी आप शेयर कर सकते हैं, इंटर्न्स को भी आप शेयर कर सकते हैं, प्रैक्टिशनर्स को भी ये यूज़फुल है. तो सीखें और इसको फैलाएं सवाब की नीयत से. जो भी हो रहा है, जो भी किया जा रहा है, अल्लाह के लिए किया जा रहा है. अस्सलामु अलैकुम व रहमतुल्लाहि व बरकातुहू.